Hello, doctors. Today, let's talk about an important topic that is about gastric adenocarcinoma. Usually, on this topic, there are many questions asked in the exams. So, let's talk about it. How we will see this topic is that first we will talk about pathological view, then we'll go to medicine view, then we will talk about the surgical approaches for this. We'll also talk about the Billroth 1, Billroth 2. So let's go. Now let's first talk about the basic anatomy of the stomach so that it will be easy for you to follow. If you see this part is the esophagus, and then there is the cardia of the stomach, and then this bulged part is the fundus. Usually if you have seen the uterus, the topmost bulged part of the uterus is called as the fundus. So just like that, in the stomach, the topmost bulging part is the fundus. Then we have the big body of the stomach. Then there is antrum, then pylorus. After that, the duodenum, and so on. So these are the basic parts of the stomach, and whenever there is cancer arising from a part, we have different treatment approaches. So keep this in mind. The most common site where gastric cancers are seen is the antrum here. Then adenocarcinoma is the most common histopathology. Now in the esophagus you might have seen squamous cell carcinomas, adenocarcinomas, but in the stomach the majority and the most are the adenocarcinomas. Then usually stomach cancer occurs after age 40. Once a person gets age 40 and so on, he develops many risk factors to get stomach cancer. So it is necessary for each and every person to go screening whenever they have some problem in the later stages of their lives. Then men are affected 2 times more than the women. This is because mainly of the risk factors that are more on the sides of the men. And these cancers are seen more in the low socioeconomic status. This is also due to certain risk factors. So let's see the risk factors. First one is family history. If a person has family history of stomach cancers, then he has more chances to develop stomach cancer. Then nitrates rich food. You must have seen these preserved foods that are preserved with nitrates, and some other preserved foods like tuna fishes, all those can cause stomach cancer. Then H. pylori infection. This infection is also an important cause of stomach cancers, and let's see how in a while. Then smoking. Smoking increases stomach cancer risk as it increases other cancer risks also. And then an important point to be noted is type A blood groups are more prone to have stomach cancers. Then atrophic gastritis. When the gastric mucosa gets atrophied, it can lead to stomach cancers. And Meniere's disease, that is cerebriform Roux-en-Y like stomach. You can see those pictures in the internet. Then adenomatous polyps, that can also lead to stomach cancer as well as colon cancer. Then KRAS gene mutation. Now type A gastritis. Basically there are type A gastritis and type B gastritis. What is type A gastritis? It is autoimmune gastritis. It is autoimmunity against parietal cells that produce acid, stomach acid. So there is decrease in acid production. This autoimmunity is also against intrinsic factor that is required for vitamin B12 absorption. So when those intrinsic factors are affected, that can cause pernicious anemia. These cancers mostly occur at the fundus, that is the topmost bulging part. And type B gastritis. B stands for bacteria. You can remember like that. So it is due to H. pylori. This causes increase in acid production causing stomach cancer. These cancers usually occur at the antrum. If you see type A gastritis occurring at the top, that is at the fundus, and type B gastritis occurring at the most common site, that is the antrum. So it, type A is proximal stomach, type B is distal stomach. Then let's talk about clinical manifestations of gastric cancer. In any cancer, the patient would have loss of appetite and loss of weight. In stomach cancer, the patient will have bloating of the stomach due to the mass present. Then, an important thing to remember is coffee ground emesis. This is seen when there is gastric outlet obstruction. When the food from the stomach can't go into the duodenum, the food builds up in the stomach and the color changes. And when the patient vomits the food, it looks like coffee ground emesis. Then acanthosis nigricans. This is mainly seen in patients with obesity and diabetes. It is also seen in stomach cancers. So it is an important thing to remember. Then upper patient can have upper GI bleeding and anemia also due to the bleeding. If you see here in the nape of the neck, this velvety shiny part, this one is the acanthosis nigricans. This is seen mainly in the obesity, diabetes and stomach cancers. Then an important slide to be remembered is this one. Many questions can come from this one slide. Whenever there is metastasis from the stomach, it can go to many parts, and so they have given different names. For example, when the periumbilical lymph nodes are involved, that is near the umbilicus, these are called Sister Mary Joseph nodule. Then when the left, not right, it's the left supraclavicular lymphadenopathy, it's called as Virchow nodes. This sign is called as Troisier sign. Then Irish node is axillary lymphadenopathy. Then Krukenberg tumors are stomach cancers that those are metastasized to the ovaries. Then Blummer's shelf is when there are deposits in the pouch of Douglas or the rectovesicles pouch. If you see here near the umbilicus, this is para-umbilical lymphadenopathy. These are Sister Mary Joseph nodule. And the left supraclavicular lymphadenopathy, this one is the Virchow node. Now let's talk about classifications of the stomach cancer. This part is purely pathology. There are different types of classifications. For example, histological, or based on the depth of invasion, or we can also have gross morphologies. So first the Lawrence classification, that is based on the histology. There are basically two types of stomach cancer according to Lawrence classification, that is the intestinal type and the diffuse type. In the intestinal type, it is seen commonly in the elderly and male population, which are normally or more having stomach cancers. But in the diffuse type, it is seen in the young and in the females. In the intestinal type, these cancer cells are well differentiated. But in diffuse type, these are very poorly differentiated cells. Then, intestinal types of stomach cancer usually occur at the distal stomach, maybe in the most part called the antrum, most common site of cancer antrum, or in the pylorus, but diffuse type are usually seen in the proximal stomach, that is at the fundus. Then at the genetic level, intestinal type has microsatellite instability. Then the diffuse type has E-cadherin deficiency. E-cadherin is nothing but usually it is holding two cells. When there is deficiency, these cells are not held together, so they can be poorly differentiated. And the intestinal type is not associated with any blood group, but the diffuse type is associated with blood group A. Previously, we also saw that in the risk factors, blood group A has more chances of getting stomach cancer. In the intestinal type, these cells are well differentiated, so they have good prognosis. But in the diffuse type, these cells are poorly differentiated and they are not held together, so they can metastasize easily. So it has a poor prognosis. And the diffuse type is usually called as rhinitis plastica. The next type of classification is based on the depth of invasion. If you see, the cancer can be just superficially spreading. Superficially means just only the mucosa. Or it can be early gastric cancer, that is both the mucosa and the submucosa involved. It can be late gastric cancer as well, when all layers of the stomach are involved. This type is called as the rhinitis plastica. The superficial spreading is considered to have good prognosis, while late gastric cancer has bad prognosis. If you see the pathological types of yearly cancer, it can be type 1 or 2 or 3. In the type 1, it is the protruded type. If you see, the mucosa is protruded here. In type 2, there are 3 types, 2A, 2B and 2C. In 2A, it is superficial and elevated. It is elevated, but it is only at the superficial level, not as elevated as this type 1. In type 2B, it is flat type. Type 2C is again superficial but depressed. Depressed, not as depressed as type 3. If you see in type 3, it is excavated, too much depressed. So type 1 is protruded, type 2 is just superficial, and type 3 is excavated. Then the Bohrmann's classification is based on the gross morphology. If you see, basically type 1 is polyploid, that is a mass that is present in the stomach. In type 2, that mass is growing now. In type 3, it is ulcerated type, that is growing inside or ulcerated. Type 4 is infiltrative, all over the stomach, all layers involved, rhinitis plastica. Then let's go to the investigation for gastric cancer. First we can do carcinoembryonic antigen, that is the tumor marker used in the gastric cancer. But this marker is not basically used for the diagnosis of the disease, but this is used for post-op surveillance. After the treatment, you will be checking levels of CEA. If these levels are low, then there is no recurrence of cancer. But when the level rises, there is recurrence of cancer. Then we have to do the gold standard investigation, that is upper GI endoscopy and biopsy. We go inside the stomach through a tube, see the mass and take a biopsy. Then we can do CACT abdomen, that is contrast enhanced CT scan. This is mainly for staging the cancer and to detect local invasions, that is nearby metastasis. With endoscopic ultrasound, you can check the gastric lymph nodes, which are important in important while removing, and we can also take a biopsy from that. And then we do staging laparoscopy, that is mainly for staging and to check for the greater omentum or lesser omentum deposits and other peritoneal deposits. Then finally we do a PET scan. This is for checking systemic metastasis, that is to check for liver metastasis, lung metastasis, or anywhere else. This is gastric cancer staging. If you are preparing for FMGE, this is really not a very high yield topic, but it is high yield for PG exams, so you can read on it. Then we finally come to the gastric cancer treatment part. The gastric cancer can be surgically not treatable, that is metastasis or very big lesion. In this we do just palliative care, that is chemoradiation, and we can do palliative debulking surgery. We just remove the big mass so that the patient would be free of symptoms. In surgically treatable patients, we have to first do gastrectomy. It can be subtotal or total gastrectomy. Then we remove the lymph nodes, D1, D2 or D3 lymph nodes. Then we do reconstructions, that is by Billroth-1, Billroth-2 or Roux-en-Y bypass. Then we can give chemoradiation. So let's talk about the treatment part in detail. First, just develop a surgical vocabulary, because when I talk about the treatment part, this is required for better understanding. Billroth-1. This is if you see the distal part of the stomach is removed and the duodenum is attached end to end. This is gastroduodenostomy. Then Billroth-2, if you see, this is also the distal stomach is removed and an end is attached to side of the jejunum. This is gastrojejunostomy. In Roux-en-Y bypass, if you see, the distal part of stomach is removed and this end is attached to this side of the jejunum. The duodenum is removed separately and it is attached to the jejunum. So these are some reconstruction methods. Now, based on the location, let's see how are we treating the gastric cancer. Radical subtotal gastrectomy. These are usually done for tumors that are at the gastric antrum, that the most common site. Then in this what we do is we remove the distal 75% of the stomach. Then we also remove the pylorus and 2 centimeters of the proximal duodenum. So distal 70% of the stomach, the pylorus is removed and the 2 centimeter of the duodenum is removed. Then the greater omentum and lesser omentum are removed with the lymph nodes. Then finally patient is reconstructed with Billroth-2 or Roux-en-Y. So basically subtotal treatment is for distal cancers. When the cancer is at the proximal part, we do total gastrectomy. So total gastrectomy is used for tumors at the body or the fundus of stomach. Here we remove the stomach completely and then we reconstruct by Roux-en-Y anastomosis. Then let's talk about gastric lymph nodes. As I said, first we have removed the stomach, then we will remove the lymph node, then we will do the reconstruction. We saw about the removal of stomach and the reconstruction. The lymph node removal requires some knowledge. So basically there are 16 groups of lymph nodes in this near the stomach. So we have to remove selectively, that is like whatever lymph nodes may be involved, we have to remove those. Here, the location of the lymph nodes are mentioned. You can take a look at it. So, how are the lymph nodes removed? D1 gastrectomy. Here, we are doing total or subtotal gastrectomy and we are removing lymph nodes 1 to 6. That is 1 to 6, all these lymph nodes. In D2 gastrectomy, we are doing total or subtotal gastrectomy, then removing 1 to 6 lymph nodes as well as 7 to 12 lymph nodes. In D3 gastrectomy, we are doing total or subtotal, then we are removing 1 to 12 lymph nodes as well as we are doing splenectomy and retropancreatic aortocaval nodes. This is not preferred due to high morbidity. Then palliative treatment. We can do adjuvant chemoradiation. 5-fluorouracil is preferred. We can also do perioperative chemotherapy, HIPEC. This is an advanced treatment. You can check on it. So that's how we treat gastric cancer. The patient is either surgically treatable or surgically not treatable. If surgically not treatable, we do palliative care. If surgically treatable, we remove the stomach, the lymph nodes, we reconstruct, and then we give adjuvant chemoradiation. So that's about gastric cancer. If you haven't subscribed to our channel, you can subscribe now. Thank you.